So we go on to our next speaker, Dr. APOORVA.A.G, who is a consultant vitreoretinal services from M.M. Joshi Eye Hospital, and she's going to talk on atypical arterial occlusion, and our discussant would be Dr. Praveen Sen.
So thank you very much for this opportunity. I am presenting a case of a 40-year-old woman who came to us with right eye painless loss of vision since 4 days. There was no history of flashes, floaters, or trauma. Yeah, so there was no history of flashes, floaters, or trauma, and no known systemic illness. She had consulted a local ophthalmologist, and she was started on oral ecosprin and clopidogrel. Also started on prolonged release pentoxifylline, clinidipine, and a cocktail of these vitamins. She had taken this treatment for 4 days without any relief. This was also the initial workup that was done by that local ophthalmologist, and her hemoglobin was normal, so was her total count, and she came to us for a second opinion. So on examination, she had a vision of just PL in the right eye. Can you hear me? I'm not getting any feedback. It's
No, go ahead, Apurva. We are able to hear you.
Clearly.
Yes, right. So the left eye had good vision of 6, 9, and 6. The right eye had a gross RAPD. There was no NVI, lens was clear. There were no anterior segment cells or flare. There were no anterior vitreous cells. So the fundus looked like this. There was posterior pole pallor, some hemorrhages at the posterior pole, a cherry red spot. Apart from that, it did look like a CRAO, to be honest, and the left eye was normal. I just took an OCT to see whether it was a large vessel occlusion or something which was a little deeper, because sometimes even capillary occlusions can have this kind of appearance. But there was a definite involvement of both the superficial and deep capillary plexus, and there was also this NFL dissociation. The octa was not very contributory because of the hyperreflective retinal layers casting back shadow. This was the FA of this patient. You can see that the arm retina time is not delayed. There is good filling of the arteries and the veins. Veins are slightly delayed, but here you can see that there is extensive macular non-perfusion. So you can see also that the capillaries are not coming up to the usual margin of the FAZ. There is abrupt termination of these capillaries at the macula. So the subsequent frames showed even more intriguing and interesting findings. Here there was perivenular and pericapillary leakage and these small bulging capillaries. These capillaries were also seeming to extend beyond the macula in the subsequent frames, but not in the periphery. So now this leakage had become more diffuse. So this was atypical in the fact that there were aneurysms, diffuse capillary leakage, venular wall staining like you can see here, and abrupt pruning of the macular vessels. So like I said, this was not a typical CRAO because there were hemorrhages at the posterior pole. It was a youngish, like a middle-aged patient, normal arm retina time, capillary inflammatory features, and abrupt pruning, staining, preferential involvement of macular arterioles and venules. The blood pressure was high, as in the diastolic pressure was 100. The other parameters seemed to be normal. We got a battery of investigations because this was atypical and we wanted to rule out inflammatory processes, and this being the COVID kind of time, so we got markers of inflammation, also got a urine microscopy, I'll come to that, and also wanted to rule out infectious etiologies. Cardiac evaluation was normal, so was the carotid. So all these parameters were normal. I don't want to read out the values, but suffice to say that everything was normal and not contributory except the COVID antibodies IgG, which was markedly positive. Just based on a hunch, admittedly, I started her on oral steroids, 1 milligram per kg body weight. She came after 5 days, vision remained poor, but I sent her to a physician to kind of find out what could be going wrong. but the only treatment the physician started was antihypertensive. This was after 5 days. You can see a marked reduction in the hyperreflectivity of the inner layers, some kind of subretinal hyperreflectivity here. The hemorrhages have come down here. The whitening has also come down on the fundus photograph. So this is a 10-day follow-up. You can see that the whitening has resolved on oral steroids. So have the hemorrhages. So these are the OCT images follow-up. So this is the crux of my presentation, which is basically about microangiopathy versus major arterial occlusions. So thrombotic microangiopathy can present with Purcell-like lesions. It can happen in post-renal transplant patients, tacrolimus-induced retinopathy, dengue retinopathy, and hemolytic uremic syndrome. To drive home my point, this is a recent publication in 2021 describing a patient of hemolytic uremic syndrome presenting with bilateral extensive capillary occlusions. So just a pearl from me is that we need to distinguish between large vessel and small vessel occlusions based on age, based on the risk factors for both of them. In small vessels, they tend to be more inflammatory, and because of flow abnormalities in the capillaries. Clinically, there will be, in addition to retinal pallor, a few cottonwool spots or Purcell-like lesions and hemorrhages. FA features will be normal arm retina time. There will be abrupt pruning of macular capillaries. There may be perivenular leakage and wall staining. And management is an extensive workup for renovascular, infectious, and immunological profile of the patient. The real pearl, however, is to know that it is not a large vessel or a central retinal artery occlusion, which the primary retinal physician treated it as. It is not a straightforward CRAO. It's a small vessel occlusion affecting the macula. And the admission is that I'm still looking for the etiology. I'm picking everyone's brains here, and I would like to thank my dear friend Dr. Mohit Dogra for helping me out in kind of looking for the cause in this patient. I've still not found it. So over to the panel, please.
So, Dr. Lovely talk, Apurva. Can we hear from you, Dr. Praveen?
Yeah, very nice case, Purva. I think lots of learning and lot of very well documented as well. As always, your cases are well documented. So just a few things which came to my mind as I saw your cases, that one is you mentioned that it is an atypical central artery occlusion. So there is definitely atypical features as arm to retina time is normal. But I I would still say that with presence of positive COVID antibody, I think all of us have seen lots of cases, and we have seen occlusion at various levels in patients who have had COVID. So I wonder if, if you had a mix of a large vessel as well as something what we call the end vessel occlusion in multiple places, which could have happened. We know COVID is a microangiopathy is associated with COVID. So that is something which could have happened. And we don't know when she had COVID, or was it an asymptomatic exposure to COVID. So the D-dimer may have come to normal, though the antibody will definitely remain high at this point of time. Also, I couldn't help but notice, I don't know whether your angiogram did show some areas of choroidal hypoperfusion as well. So I'm not sure whether the posterior ciliary arteries were also, see this, if you see nasal to the disc, the next frame. So there are some areas, and as well as superiorly some isolated areas of choroidal hypoperfusion.
Yes.
So which would mean that the choroidal capillary, choriocapillaries, which act as a separate end artery, they are also end arteries. So maybe they are also involved, which are adding to ischemia. And these small capillary vessels, when they traverse through an area of ischemia, they tend to be leaky. So whether it is just that hypoxia, which is causing the vessels to be leaky and not really true inflammation, is another aspect which needs to be kept in mind when we interpret this leakage. Recently, another issue is that we had a recent case presentation, I think last year, if I'm not mistaken. Dr. George had presented one case on oxygen hypoperfusion retinopathy. So it is something which has been described recently by Dr. David McLeod, and he has mentioned that you may not have a complete CRAO, but you may have something like a partial CRAO, where you may not develop a cherry red spot, but in your case there was a cherry red spot. So that there is hypoperfusion, chronic hypoperfusion, which gives rise to this kind of ischemic changes as well. So you don't get the typical arm to retina time delay, but there is definitely a oxygen-based hypoperfusion which is happening, and which will give rise to this opacification of the inner retinal cells. And OCT angiogram would have probably helped to see whether the deep capillary plexus was more involved vis-a-vis the superficial capillary plexus. So that is another thing. And I think if we are really looking at a choroidal hyperperfusion, I think a carotid Doppler study is also sometimes very useful in pointing out as to where lies the. But I would probably at this point of time, in this time, point it at COVID giving rise to microangiopathy and hypoxia of the retina. A very nice case. That's all from me. If any other comments are there from other panelists, I'd like to hear them.
Ma'am, COVID antibodies were probably positive due to double vaccination, I thought, because now it's very difficult because mass vaccination. We don't know whether the IgG is raised because of the past
So
infection.
I think there are some lab who they do something called IgG antibody, which shows you the previous COVID infection, and then there are separate antibodies for the vaccine also, which are the neutralizing antibodies. So I think the two different type of tests probably some labs use, which could detect the difference.
Okay,
But,
I was not aware of that. Okay.
you could try.
Thank you. But wonderful discussion and a wonderful